So good evening, everybody. On behalf of EIZOC, I welcome you all to this first session of EIZOC Grand Round clinical case discussion. This has been added this year to increase our clinical knowledge and to interact with our fellows and residents. And everybody will gain out of this exercise. So I request now our President, Dr. R.C. Meher, to give his welcome address.
Friends, good evening to you all. Namaskar. Present EIZOC advisors, Professor Shahaji, other members, yet I think Dr. Abhijit Ghosh has not joined. Yes, President-elect P.N. Gupta has not joined. And all esteemed EIZOC members, I express a warm and hearty welcome to you all to this EIZOC Grand Round case study, which we are starting for the first time in our EIZOC. This case to be presented by Dr. Nikita Das, Senior Resident AIMS Bhubaneswar, and Dr. Janikson Jairaj, Junior Resident AIMS Bhubaneswar. I thank our Chairman Scientific Committee for active preparation and starting of this webinar of case studies. I expressed my hearty thanks to our Chairman Scientific Committee, Dr. Sabyasachi Patnaik, and encourage him to keep it on. I also welcome and congratulate the chairpersons, Professor B.N.R. Subudhi, Dr. Pranav Ranjan, Dr. Abhijit Ghosh, Dr. B.N. Gupta, and Dr. Biraj Goswami. My special thanks goes to Chief Coordinator, Professor B.N.R. Subudhi, and Moderator, Dr. Sucheta Parija, Associate Professor and Head of the Department of Ophthalmology in AIMS Bhubaneswar, and Bhagavat Naik, Assistant Professor, AIMS Bhubaneswar. Friends, regarding members for managing committee, actually we have for 4 states, that is for Arunachal Pradesh, Meghalaya, Tripura, and Sikkim. 4 states are yet left. 4 states are yet left for selecting this managing committee member. So today I declare the managing committee members from Mizoram, Dr. Mrs. Lalbia Luangi, Dr. Nupuli; from Nagaland, Dr. Ohoke Sikhu; from Manipur, Dr. Liasaram; and from Andaman Nicobar, Dr. Rohindra Lal. So we have finalized these 4 managing committee members of these 4 states. Friends, another thing, we will be having our next executive committee meeting on 10th of March, that is Thursday. We'll be discussing about our venue and time for mid-conference 2022. Also, we can have some other discussions. Thanking you all. Long live EIZOC. Thank you very much.
Thank you, sir. Now I request our Secretary General, Dr. Suraj Bhattacharya, to give his report. You are muted. You are muted, Dr. Suraj.
Mute. So good evening, everybody. At the onset, I'd like to play the EIZOC video to show everybody what is our aim and our situation in EIZOC. Could you hear?
It's not started yet.
Okay. Working. Could you see? This is all about our EIZOC. Now from the secretarial desk, I'd like to share a few things. Thank you, President. Good evening, everybody from EIZOC Secretariat. We are here again together for being a part of the webinar Grand Round 1. The Grand Round always remind us of our residency days where our HOD with a full team of teachers and residents were interacting on different clinical situations, sharing all practical tips. Thank you, our Chairman Scientific Committee, Dr. Sabosati, under the guidance of our President, Dr. R.C. Meher, for choosing the topic, case studies. The aim of the EIZOC webinar is also to give a platform for young generation to come up with academic activities and also to tighten the bond. Today, our Chief Coordinator, B.N. Subudhi sir is there. He will be taking care about coordinating the presentation given from the AIMS Bhubaneswar. And our Pariza madam is there. She is also taking care about how they're doing. And in addition, the membership strength is our power of any organization. And I request our residents and young brigade to take the membership of the EIZOC and be a part of it. We plan to do this type of webinar bi-monthly. And in addition, our new chairman ARC, Dr. Y.C. Mehti, also planning to have a few ARC activities during the year. Just for reminder, our annual conference has been scheduled to 26th and 27th of March at Puri. And those of us yet not registered, please do it and be a part of the great event. Thank you so much. I take this opportunity to request our host, keep the persons in mute condition unless when they speak, they please do unmute only.
No, sir.
Thank you so much.
Thank
Over
you,
to
sir.
Chairman Scientific Committee.
Thank you, sir. Now we'll start our program, the grand round number 1. So I must thank Dr. Sucheta Parija Madam for agreeing to our request of having this program and volunteering to take this responsibility of having the first one in the name of AIMS Bhubaneswar. What we have planned is every month we will have a grand round webinar and it will be institution-based presentation so that we can know in the EIZOC states who are the prominent institutions and what are the facilities and what are the quality of work they are doing. So thank you, madam. I must thank our chief coordinator of this program, Professor B.N.R. Subudhi, for agreeing to our request, and I request him now to start the program. Thank you.
Thank you, Dr. Sabyasachi Patnaik, our Chairman Scientific Committee, EIZOC. Respected President, Dr. Meher, Secretary, Dr. Swaraj Bhattacharya, and respected Senior Professor, Professor Bimal Sahai, and all my colleagues. It's a really great opportunity to share our knowledge among the eastern states. As our CSC already said, that so many beautiful institutes are there in our these EIZOC states. If we can create good academic sphere amongst us, and at national level you can compete with the national academics. That's the purpose of starting of this grand rounds. It's based on clinical case presentation. Theoretical presentation we have discussed so many times, but it's not much benefit to our residents and our junior scientific people. So I think case presentation is really interesting, and we in our state society webinars, WhatsApp group also, we got a lot of case presentations and case discussions every day. So really interesting, and the starting is from AIMS Bhubaneswar, and really I thank Professor Sucheta Parija, additional professor and head of the department of AIMS, to come forward with the 2 case presentations. Today we had a very nice case presentations, and one is on the B pattern exotropia and second the IC syndrome. Rightly, there are 2 residents, one senior resident, Dr. Nikita Das and Dr. Zerikson will be discussing. And I think the plan is first one case let us present and then discuss. Then after finishing that case discussion, then we'll go for the second case and we'll discuss. So without not wasting much time, I give my podium to Dr. Sucheta Parija to start the first case presentation. So it's over to you, Dr. Sucheta.
Good evening, everyone, and thank you all the president, chairperson, and for giving us this opportunity to present the case. So I request Jenickson, our second-year junior resident, to start his case presentation, which is on V pattern exotropia. So after his presentation, we can discuss the important points, and then we can go to the next case. So Dr. Jenickson, please share your slides.
Yes, ma'am. So a warm good evening to all dignitaries, doctors and gurus of ophthalmology. It's been great pride and privilege for me and to be a part of this first clinical grand round series program. I would like to thank all the delegates and doctors, especially my guide and moderator, Dr. Sucheta Parija, for giving me this opportunity. So myself is Dr. R. Jenickson Jairaj, Junior Resident of Department of Ophthalmology, AIMS Bhubaneswar. So I'll proceed with the case presentation. My patient is a 20-year-old male who is a resident of Nuapada, Odisha, presented with complaints of outward deviation of right eye noticed since early childhood, which was constant in nature. There was no associated diurnal variation, no aggravating and relieving factors, No associated visual complaints like diminution of vision, diplopia, asthenopia, or photophobia, and no head posture. There was no history of use of any spectacles, no history of any trauma, no history of any previous treatment in the past, or no history of any previous ocular surgeries. Coming on to the systemic history, the patient is not a known case of hypertension or type 2 diabetes mellitus. There is no history of any neurological symptoms, no history of head injury. Birth history, the antenatal, perinatal, and postnatal period was uneventful, and the patient attained milestones appropriate to age. Personal history, the patient is a student belonging to a medium socioeconomic status. He consumes mixed diet with normal bowel and bladder habits. He's not a smoker, and patient is not an alcoholic. There is no history of strabismus or any other ocular abnormalities among family members, no history of any ocular tumors, or no history of any ocular surgeries among first degree relatives. Coming on to the general examination, the patient is conscious, cooperative, well oriented to time, place, and person. He is of well built with the vital stable, and the preliminary examination was uneventful, and the systemic examination was also uneventful. Ocular examination, the patient's unaided visual acuity for distant vision is 6/6 in both eyes, and for near vision it is N6 in both eyes. And the color vision was normal in both eyes, and the intraocular pressure by non-contact tonometry is 13 millimeters of mercury in the right eye and 10 millimeters of mercury in the left eye. So on inspection, the head posture is normal, the face is symmetrical with no ptosis or pseudotosis. There is no change in width of the lid fissure with ocular or jaw movements. And the interpupillar distance was measured to be 68 millimeters. Motor status evaluation. On performing Hirschberg's test, it showed right eye outward deviation approximately 15 degrees to 30 degrees. On performing cover test, it was found the right eye was found to have exotropia for both near and distant vision. Alternate cover test showed alternating fixation. And the extraocular movements of the patient were full and free for both eyes. And so this is the 9-gaze photograph of the patient when he presented to us. As you can see in the as you can see in the picture in the primary gaze, you can notice there is right exotropia. And the other respective 9-gaze photos are here in this presentation. So when you see on the up gaze, there is a little bit of more divergence as compared with the down gaze. So this gave us a suspicion of a patterned strabismus, like patterned exotropia in this patient. And so we moved on with the prism bar cover test. So basically the prism bar cover test is performed placing the prism with its apex towards the direction of the squint, or else we can say it as the base will be in for exotropia and the base will be out for esotropia. So this is how we see it in the primary gaze, and the up gaze would do it at 25 degrees and for the down gaze at 35 degrees. So this is the prism bar cover test by interpretation for distance, showing 45 prism diopters placed in primary gaze, and in up gaze it is 50 prism diopters placed in.
So the speaker is muted.
Hello.
You can continue, Janik.
And so the so on primary gaze, the deviation was 45 prism diopters. On up gaze, it was 50 prism diopters, and 35, and in down gaze, it was 35 prism diopters for distance. So from this prism bar cover test, the difference between the down gaze to up gaze is around 15 prism diopters, which is significant of B pattern exotropia. And the similar result was also achieved on prism bar cover test for near vision. And sensory status of the patient is examined with Worth 4 dot test, which was suggestive of right suppression, and Lang's 2 pencil test, which showed no gross stereopsis to the patient. And anterior segment evaluation with the slit lamp showed the lid adnexa conjunctiva with normal, cornea is clear, sclera is normal, the anterior chamber is normal in depth, pupil is regular round reactive, and the lens is clear. And fundoscopy was done for the patient, and the fundoscopy was grossly within normal limits, and there were no torsional changes present in the patient. So summarizing my case, this is a 20-year-old male patient presented with complaints of outward deviation of right eye noticed since early childhood. On examination, there was no abnormal head posture. Right eye exotropia around 15 to 30 degrees by Hirschberg's test. Cover test demonstrated right exotropia, and alternate cover test showed alternating fixation. The extraocular movements were full and free. And the prism bar cover test demonstrated an increase in exo deviation from down gaze to up gaze by 15 prism diopters. There was no gross stereopsis present. Anterior segment findings were within normal limits, and the fundus examination is normal with no torsional changes. So the probable diagnosis of the case is a V pattern exotropia with no oblique dysfunction. So moving on to the management, the patient was planned for surgery, and routine investigations were done like complete blood count, viral markers, PT, APT, INR, LFT, RFT. Because the patient is planned to be operated on general anesthesia, and anesthetic clearance was done. And the surgery performed was lateral rectus recession, 8.5 millimeters with upward transposition, and medial rectus recession, 6 millimeters with downward transposition under general anesthesia. So this is a surgery video. Initially, we start with performing the forced duction test, and the conjunctiva is cut open. After cutting open the conjunctiva in the lateral side, the lateral rectus is first identified and hooked. After hooking of the lateral rectus and clearing out the tenons from it, we will fix the lateral rectus at the point of insertion first with the 6-0 absorbable vicryl sutures double-ended. After fixing it, you separate or you cut the lateral rectus from its site of insertion. Once you free the lateral rectus from its site of insertion, you use calipers to mark the amount of recession required, and you are about to transpose the lateral rectus. So you are transposing the lateral rectus in like upper towards site of insertion. Previously, it was normally inserted. Now we are transposing it superiorly. So similarly, on the other side, the medial rectus is also exposed, and medial rectus is about to be resected. So the resection, the amount of resection is marked, and it is cut from the site of insertion, and it is placed inferiorly, and the rest of the medial rectus is cut. And after the procedure is being done, the conjunctiva is closed with 80 vicryl sutures. So this is the post-operative day 1 of the patient. On examination, the patient had mild exotropia, and the conjunctiva was congested with the sutures intact, and there is no signs of inflammation present. So he was given medications like hydroxymoxifloxacin, hydroprednisolone, and an injectable antibiotic was given, along with painkillers and analgesics were given. So after 1 week of post-operative period, again the 9-gaze photograph is taken. So in this photograph, you can see in the central primary gaze, there is mild exotropia is present in the right eye, and there is no significant pattern a pattern cannot be significantly detected in this 9-gaze photography. So after 1 month of post-operative follow-up, the patient was asymptomatic. Like he was doing good with this surgery and he was happy with the surgery. And on examination, there was mild residual exotropia. Like on Hirschberg's test, it is less than 15 degrees. On prism bar cover test, there was a deviation neutralization at 10 prism diopters in basin, and there is no significant pattern present. So these are the post-op, so the pre-op and post-op pictures of the patient for comparison. So little bit about V pattern exotropia. This is one of the common alphabet patterns you can see. V pattern exotropia is increase in the pattern of exo deviation from down gaze to up gaze, the difference of more than 15 prism diopters. It usually often results due to oblique muscle overaction or paresis. So management, according to Kenneth W. Wright, for V pattern strabismus with minimal or no oblique overaction, like the treatment modality is transposing the medial rectus inferiorly, that is towards the apex of the alphabet, and to transpose the lateral rectus superiorly towards the white part of the pattern. So this is one of the journals, one of the articles that is published in American Association of Pediatric Ophthalmology and Strabismus, which showed the effectiveness of vertical offset of horizontal rectus muscle in V pattern exotropia without oblique dysfunction. So, like this they concluded that this surgery, if there is no oblique dysfunction for V pattern exotropia, horizontal rectus transposition surgeries are showing good outcome. And one more article presented in Pakistan Journal of Ophthalmology, where they discussed varieties of pattern strabismus and their surgical outcomes. In that article also, it has shown they have concluded that various rectus muscle transposition surgeries can be useful for correcting the pattern strabismus. Thank you.
So to take up the case from here, just what is important or why did we present this case? Now, a lot of cases, they come with just exotropia, that is a horizontal strabismus, which usually we encounter in our OPDs. Why it is important to look at the any pattern which is there, like we say A or V pattern, that is, what does it mean? If you have a exotropia or a esotropia, and what is happening, this is the horizontal committant exotropias which you have, but when they look at up gaze or down gaze, there is a vertical incompetence, and that is how they present as a or a V pattern. So why important in this case is because your surgery differs. So, and if you have a different surgery and you just correct the exotropia, not taking into consideration the V pattern, then the results will be a failure, and you can undercorrect or overcorrect the case, and finally leading to dissatisfaction of the patient. What is the importance of V pattern? Why there is a V pattern, or what is the etiology? So if you look at the most, there are different theories behind it. And the first theory was the horizontal theory school of thought by Ursit et al. What they wanted to say exactly was that you have an overaction of the lateral rectus mode in the up gaze. So it tries to pull the muscles outwards, and that is how you are getting a V pattern. But what subsequently came into being was the study by Kushner et al., who wanted that the obliques have a dysfunction, and if the inferior oblique overaction is more seen with the V pattern. There is also another school of thought where they say that it is the vertical school incompetence which is occurring. That is, if you think about the superior rectus which is weakened, so they have an action of abducting things. So if the superior rectus is weak, so what will happen? It will pull more towards the abduction will be occurring, and they have an overplay with the oblique. So oblique, the function, tertiary function is abduction. So what it will try to do, along with the elevation, it tries to abduct the muscles. So you get a V pattern when you are having an up gaze. So important point is when you are having chin up, the patients sometimes come with an abnormal head posture with a chin up or a chin down position. So you have to always measure from down to up gaze and see the difference which is there of 15 prism diopters in exotropia, that is V pattern, or when we see a pattern, that is 10 prism diopter. So sometimes you have to, why we said about neurological cases, or we have to do a imaging if we see that any structural factors are playing into play. some of the craniostenosis cases, or cruisons, they come with different V phenomena, and tackling the which muscle you will be tackling, that is one of the important points in those cases. And sometimes what happens, you have abnormal, the pulley, which is the most common factor which is coming into play. So anomalies of the muscle insertion, that also gives you an idea why this V pattern is occurring. So considering, so if a postgraduate, when he's reading, how do he examine? These are the things of orthoptic, how they examine a squint patient. And first of all, you have to see what the deviation is. You see a exotropia, esotropia, whether it is having any pattern, what is the ocular motility, whether you have a oblique dysfunction or not, what is the stereopsis, the sensory status. Then you quantify the strabismus which is there with the prism bar cover test, and then only you can formulate your action. So in this case, what happened? Since there was no oblique dysfunction, we did not tackle the oblique muscle. Otherwise, V pattern with inferior oblique overaction, we should have gone in to do a inferior oblique tenectomy or weakening procedure, and the most common we go for transpositions of the inferior oblique to take care of the V pattern, which usually collapses. Now, in our case, since there was no oblique dysfunction, we just tackled the horizontal muscles, that is the medial and the lateral rectors, taking care of the primary position exotropia, and we half tendon transposed it to take care of the V pattern which is there. So this is what is the basic understanding which I have to convey. So any questions we can take up, or we can go to the next case. So will we proceed to the next case?
I think we should go.
Any questions
Yes.
from any residents?
I don't think everything is well understood.
Sir, any questions, or we'll proceed to the next case?
I think we should proceed to the next case. It is well explained by you, so we can go to the next case.
So I call upon Dr. Nikita to present her case.
Thank you, ma'am. Thank you for this opportunity. So, a very good evening to everyone, respected dignitaries of EIZOC, faculties and residents.
Can you come with the video, Nikita?
Yes, sir. So can you see the screen?
Yes, yes.
Yes, ma'am.
So, a very good evening, everyone, respected dignitaries of EIZOC, faculties and residents. I take immense pride in presenting on behalf of my institution in the first episode of the Grand Rounds. And I thank my HOD, Dr. Sucheta Parija, and my mentor, Dr. Bhagwat Nayak, for this opportunity. So I'll be presenting on iridocorneal endothelial syndrome and its management. It's a 2-case series. These 2 cases are similar in presentation, but they differ slightly in the management. So my first case was a 35-year-old female from Midnapur, West Bengal, who presented with diminution of vision in the right eye for 1 year. Then there was sudden onset of right eye ocular pain, redness and burning sensation for 1 month. This was associated with photophobia, colored halos and watering. There was no history of ocular trauma, any systemic comorbidities or significant family history. And on assessment of systemic examination, she was found to be normal. So we moved on to the ocular examination. So this was her, how she presented with her right eye. The vision, the best corrected visual acuity in the right eye was counting fingers at 1 meter, with PR was inaccurate in 1 quadrant. There was circumcorneal congestion and a hazy bullous keratopathy in the cornea, shown by the yellow arrow. And as you can see, there were DM folds as shown in the blue arrow. We did an intraocular pressure measurement. Since the non-contact tonometer could not get a reading, so we had to do a Goldman applanation tonometry for this patient, despite the corneal edema. And the reading was 50 millimeter of mercury in this patient, in this eye. In the left eye, the cornea, the best corrected visual acuity was 6/9. The conjunctiva was normal, but the cornea had a clear, cornea was clear, although clear, it had a beaten silver appearance. And there was mild iris atrophy as shown in the yellow arrow. So since the right eye had a hazy cornea, so we could not do a gonioscopy in the right eye, but we could perform a gonioscopy of the left eye. And on gonioscopy, we could see that there was a high iris insertion with non-visualization of the trabecular meshwork along with peripheral anterior synechia. So this is the gonioscopic picture. So this shows the high iris insertion, and there was no trabecular meshwork visible, as you can see. And there was a peripheral anterior synechia. And in the left eye, we also did a specular microscopy, which revealed that there was a decrease in the cell density, a mild decrease in the hexagonality of the cells, and there was a increase in the coefficient variation of size, suggesting that there was a change in the endothelial cell architecture and a tendency towards polymegathism. So we diagnosed this as a bilateral case of ICE syndrome with right eye secondary glaucoma along with corneal decompensation. Then we started on the management. We had to give intravenous mannitol with topical aqueous suppressants and topical sodium chloride 5% to resolve the epithelial edema. Once the epithelial edema decreased, we moved on to planar right eye trabeculectomy with mitomycin C. So on the post-op day 1, the IOP decreased to 15 millimeter of mercury and the visual acuity improved to counting finger at 2 meters. But then again, on 2 months post-op, there was bleb vascularization that led to an increase in the IOP. So the IOP increased to more than 25 millimeter of mercury. So therefore, we had to do a bleb needling with mitomycin C. Then on final discharge, her final IOP was 12 millimeter of mercury and visual acuity did not improve more than counting finger at 2 meters. So this was a pre-op image. As you can see, this was post-op day 1. The edema has improved slightly better than the pre-op image. And this was the post-op day 1 bleb formation, which was a well-raised bleb. There was no leakage and the anterior chamber was well formed. But later on, 2 months, she started developing this vascularization, for which we had to do a bleb needling with mitomycin C. Now, moving on to the next case. She was a 39-year-old female who presented with pain in the right eye for the last 8 months. Then there was diminution of vision of the in the right eye for the last 8 months. She did not suffer from any photophobia, colored halos, and there was no history of ocular trauma, systemic comorbidities, no significant family history. Systemic examination was absolutely normal. So we moved on to the ocular examination. So this was her presentation. In the right eye, her best corrected visual acuity was 6/60. And there was circumcorneal congestion, mild circumcorneal congestion. The cornea had a hazy beaten silver appearance. And as you can see here, there was atrophy of the iris tissue. There was a lot of atrophy of the iris tissue giving rise to a pseudopolychoria, a hole in the iris. And since there was atrophy in this part of the tissue, due to the sphincter action, the pupil had moved to another side, leading to a correctopia. When we measured the IOP on Goldman applanation tonometry, it was found to be 58 millimeter of mercury. Whereas in the left eye, the vision was absolutely normal, 6/6, and conjunctiva and cornea were normal. There was no issues with the cornea conjunctiva. Iris tissue was normal in structure, and the pupil was 3 millimeter, round and regular, reacting to both direct and consensual light reflexes. Intraocular pressure was 14 millimeter of mercury on Goldman applanation tonometry. Then we did a funduscopy of this patient. As you can see, the right eye fundus photo was a little hazy because of the hazy cornea, as well as there was some early lens changes. But you can see here that the cup disc ratio was about 0.8:1. Whereas in the left eye, it was absolutely normal. about 0.4, 0.3, 0.4:1. Then again, we did a retinal nerve fiber layer OCT for this patient, where you can see in the right eye, the parameters are highlighted in red. And you can see the average cup disc ratio has increased to 0.8, 0.9. And there is thinning of the retinal nerve fiber layer as compared to the left eye, where the retinal nerve fiber layer is is normal, and the parameters are in green. Then we did a specular microscopy of this patient, where you can see that there is a decrease in the endothelial cell count, much decrease in the hexagonality, and an increase in the coefficient of variation of size as compared to the left eye. So basically, hexagonality indicates that the cells are hexagonal in nature. There is no polymegathism present, or there are no changes in the endothelial cell architecture. And coefficient of variation of size suggests that the variation between the size of the endothelial cells is not much. So that's why a decrease in hexagonality and an increase in the coefficient of variation of size indicates indicates a change in the endothelial cell architecture and possible polymegathism going on. So this patient was also diagnosed as a right eye ICE syndrome with secondary glaucoma. We had the differentials of Fuchs dystrophy in mind, but then Fuchs dystrophy will not cause such an increase in the IOP. Then posterior polymorphous dystrophy, it is usually congenital in nature and people present earlier. Axenfeld-Rieger anomaly the iridocorneal dysgenesis may present like this, but then again, they will present at a younger age, and they may be associated with other systemic anomalies as well. So we started with intravenous mannitol to decrease IOP first, then also started her on aqueous suppressants and maximum medical therapy. Then we decided to plan for a right eye trabeculectomy with a biodegradable collagen matrix, or the Ologen implant. Following the trabeculectomy, the post-op IOP reduced to 4 millimeter of mercury, and there was a shallowing of the AC, anterior chamber, that led to a choroidal detachment, which was visualized on B scan of the patient. But the vision was 6/36. Then to manage the choroidal detachment, we had to start the patient on oral corticosteroids. Then we tightened the sutures. Then IOP increased to 10 millimeter of mercury. However, at 3 weeks again, fibrosis developed. So as a result, the IOP increased to 25 millimeter of mercury. Then again, we had to do a bleb needling also in this patient. The post-op follow-up at 1 year showed that the IOP was maintained at 10 millimeter of mercury, and the visual acuity remained at 6/36. So these are the post-op images. This is the day 1 post-op, where there was a shallow AC. Then here you can see in the B scan, these are the choroidal detachments, following which we had to start the patient on oral corticosteroids, and we had to tighten the suture. Then once the choroidal detachment, as you can see, that led to the management of the choroidal detachment. However, later at 3 weeks, there was again bleb fibrosis and vascularization of the bleb, for which we had to do a bleb needling with mitomycin C. And this was the final post-op image at post-op follow-up at 1 year, showing a well-elevated non-vascularized bleb. So coming to the discussion part, iridocorneal endothelial syndrome is a rare ocular disorder, and it comprises a group of conditions.
Nikita ma'am, will you just unmute yourself? Please unmute yourself. Dr. Nikita, yes.
Okay. So iridocorneal endothelial syndrome, they comprise a group of conditions characterized by structural and proliferative disorder of corneal endothelium that cause anterior chamber, angle, iris, and pupil abnormalities. So basically, it has three clinical variants with overlapping features. First is the Chandler syndrome, where second is the essential or progressive iris atrophy. Third is the iris nevus or Cogan-Rees. The common factors to all the three syndromes is the presence of a hammered silver appearance of the endothelium. So Chandler syndrome is basically corneal and it presents with mostly corneal edema and colored halos with variable iris atrophy on correctopia features. Essential progressive iris atrophy, like I had presented in the second case, they mainly have the iris atrophy as the presenting feature. And in iris nevus or Cogan-Rees syndrome, they have multiple iris nodules along with the hammered silver appearance. So basically what happens, the endothelium of the cornea, it starts developing some contractile properties, and as a result, it starts to proliferate over the chamber, anterior chamber of the angle of the anterior chamber, thus causing blockage of the anterior chamber. And these contractile elements, when they develop contracture, it can cause a peripheral anterior synechia. So trabeculectomy with antifibrotic agents is usually the surgery of choice. However, the success rates are they start to decrease at about 3 years. They have strong initial success rates, but later on they start to decrease. Antifibrotic agents, we can use mitomycin C or 5-fluorouracil. Now, a biodegradable collagen matrix has come up for the treatment of secondary glaucoma due to synechial angle closure. So this was a study that was done by Chandran et al., who studied on the epidemiology of iridocorneal endothelial syndrome in Indian subjects. And they found that like uniocular presentation is more common, and it is more common in middle-aged women. However, bilateral presentation can be seen in 10% of cases, and like we had seen in our first case. And progressive iris atrophy is the most common clinical variant, which was our second case, followed by the Chandler syndrome, which was our first case. Then they had also done a study on the outcomes of trabeculectomy with mitomycin C in glaucoma secondary to ICE syndrome. And they found that primary trabeculectomy, it offers moderate surgical success with ICE syndrome. And long-term IOP control and corneal clarity in these eyes is a big challenge. Then, like I said, the Ologen implant, it has been studied in other causes of synechial angle closure. There haven't been many literature on the use of Ologen implant in ICE syndrome, but Radhakrishnan et al., they have reported a case where they found that it was good enough to manage glaucoma in a case of Axenfeld-Rieger syndrome. So the main causes of failure that lie in an ICE syndrome are robust subconjunctival fibrosis and endothelial membrane, which can grow and occlude the filtering ostium. So that's why, considering the intractable nature of this disease, aqueous shunt surgery is considered to be more better as compared to trabeculectomy. However, it still has, it's not without any issues, because shunts, they have a cost issue, obtainability issue, along with many ocular side effects like diplopia, strabismus, then the tube erosion, endophthalmitis. So this was a study that was done by Kim et al., wherein they found that although the aqueous shunt surgery was an effective method for IOP lowering, however, additional glaucoma procedures and shunt revisions were quite common in these cases. So I would like to conclude by saying that detailed examination and proper investigation can help us diagnose, manage, and prognosticate IC syndrome better. But if we are to do a trabeculectomy and we want to ensure the success of trabeculectomy, then we need to do a long-term follow-up of the patient and manage the complications that come along with it. These are my references. Thank you so much.
I call upon Dr. Bhagwat to moderate this case. Dr. Bhagwat, please.
Yes, ma'am. Thank you, Suchita madam, or HOD. And first of all,
Please
I'm
stop
happy.
sharing.
Nikita, stop sharing. Okay. So first of all, I am thankful to the Eastern Zonal Indian Ophthalmology Conference to giving opportunity to the AIMS Bhubaneswar. And thank you, HOD madam, for opportunity to me. And respected President Sir R.C. Meher sir, and Secretary Dr. Suraj Bhattacharya sir, Dr. Sabyasachi Patnaik sir, Chairman Scientific Committee, Chief Coordinator Dr. Subudhi sir, as always you are active, and Dr. Pranav Ranjan sir, I think you have forgotten me. We have met at AIC 2020 Gurugram by your Dr. Pranita.
Yeah, I remember.
In a glaucoma session. Okay.
Yeah, you were there.
So, and all other dignitary residents. So basically, why I took these two cases were they had come during the COVID session. Okay, from the both are from the Medinapur, unrelated. They are unrelated. The first case was that came with right eye corneal edema, bullous keratopathy. So and high IOP, very high IOP. So we could not assess what is the cause of this high IOP. Whether it is like any other secondary glaucoma or something like this. So when we saw, because the iris little were not visible at that time, but when we saw the other eye, that is left eye, you can see there was a patchy iris atrophy in that eye, and then I suspected diagnosis some like ice or something other like iridodegenesis type things. Then when is like focused to the endothelium, as we see in some ladies cases like pigs, like etc. So we saw like some bronze bitten appearances. Then we sent for the spectral microscopy, and spectral microscopy shows all the things. There was a hexagonality decreases, coefficient variation increases, and there was a typical like ice cell type. Like basically the ice cell is like the cell is like hypo, and the center is like hyper reflective. So we suspected the other eye might have like same features leading to secondary glaucoma. At that time, we are not confirmed the second eye having the same thing. So when after the surgery we proceed after mannitol, etc., hyperosmotic agent and sodium chloride 5%, etc. So we did surgery. After surgery, when the cornea cleared, we saw there was also some iris patchy atrophy in the margin. Then we thought it may be the bilateral eye syndrome type features, and mostly this may be the Chandler syndrome. Then in why this we took this case, we presented this case. In our mind, from the residence cases, it was thought that it is a unilateral, like middle-aged woman present like this. So when we saw the literature, as Dr. Nikita showed, there is a larger study with 203 cases by a group of from LB professor. There is only 10%. I didn't know that. Even in last year, IGO, that is from S. Panda from the PGI, they have presented one case, bilateral Chandler syndrome. They written that it is a unique rare cases. So anyhow, we managed. First thing is diagnosis of these cases is very much important. And you can take help of the spectral microscopy. Nowadays, like in vivo confocal microscopy, they present with the typical IC cell features. And also you can take help of ultra biomicroscopy to see the like high insertion of iris pass, etc. when there is not, when their iris is not visible. So these are the investigative modality. Coming to the surgery part, as you know that in 70 to 80% of cases, the medical management will fail. Yes, you have to reduce the IOP before surgery, and you can check also whether it is controlled or not. But a majority of the need surgery, and among the surgery, there is still a debate going on. What these glaucoma are intractable glaucoma. They will not the success will be not good as a normal POEG, PSEG glaucoma. Because as the pathophysiology says, no one knows what is the cause. Some they're thinking that it is a proliferative endothelium, like having the epithelial type features, mitotic activity. And some studies say that the herpes simplex virus may have some replication in past because they have got some aqueous humor, HBV DNA, etc. But they're not sure. In many there studies going on, etc. So what the blade will fail mainly because there is then the intractable membrane may close your ostium. There may again that fibrosis occurs, etc. So the failure chance is more. But as that patient was like non-IDPR inaccurate, corneal was severely decompensated, like they need cornea transplant, etc. So we did, and obviously the patients are poor. So we did first only simple trabeculectomy with a antifibrotic agent like mitomycin C, as I do all with 0.04 percentage, 0.4 milligram per ml, because this is a high chance of failure. So the patient did well first. There is some days, 2 months after that, the bleb became failing. When the bleb is failing, this is the right time you have to intervene. Once there is a failed bleb, like 6 months after that, your bleb revision, bleb needling, etc. not work. When there is a bleb is failing, you should take the signs. You should see the signs of bleb failing, like hypervascularity, corkscrew vessels, just slightly elevation of the IOP. At that time, you should try a bleb needling. As you know, bleb needling is not a like ice on cake. You will ice that cake work. You will just go and do all the things. There is all have some complications. So in the bleb needling, with mitomycin C injection, as we didn't get 5-fluoro injection, otherwise I prefer 5-fluoro. Mitomycin injection 0.2 milligram in 0.09 ml, 10 millimeter apart from the ostium we gave, and we did the bleb needling. Then the patient actually the IOP decreased to 12 millimeter mercury. I am saying they were first case, but after that she was admitted for 7 days, etc. But after that, COVID patient didn't came to our follow-up. That means so we could not assess the what is the post of, like it is nearly about 1.5 years. So that was the first case. So my diagnosis in first case was probably this is the bilateral Chandler syndrome and having secondary glaucoma in right eye. So in the second case, it is a unilateral, typical unilateral case, having like progressive iris atrophy. As you see, there is a stretched holes, large stretched holes, confusing with pseudopoperia, and other eye has a normal endothelium, etc. But and the affected eye has like decreased hexagonality. As you know that in spectral microscopy, hexagonality, our normal eye have 50 to 60% of more than 60% hexagonality. It should be, and coefficient variation should be less than 20 to 30%. But here the coefficient variation increases and hexagonality decreases, and that is a typical eye cell type. So again, there is a iris pattern was like iris cell, and gonoscopy was saying all these things. So gonoscopy, what will say? Basically, it may be high insertion of iris, it may be peripheral anterior synechiae, it may be like tabular muscle not visible, obviously. So it is like a peripheral anterior synechiae or high insertion of iris. That is endothelialization. That is membrane may cover all the tabular muscle by fibrosis. So it went in favor of IC syndrome, and patient was obviously female. So we planned for after reduction of the IOP with maximum medication from 58. As you know, more than 40-50 millimeter mercury you cannot control with medications, topical medication at least. So patient we need surgery, and the cupping was 0.8, 0.9 cupping in right eye. Cornea was hazy. So we planned for surgery, and surgery this time we thought for the Vologen. I have experience of Vologen since many years, and although I am not published, but all the patients are doing good. Although there is controversial study that they say Vologen versus mitomycin, they have equal benefit, no advantages of Vologen over them. But there are also study meta-analysis said that although there is the efficacy is same, but the bleb related complications like hypertony, endophthalmitis, suturing, suture lice, etc. They're more in the mitomycin. So if Ologen is available, patient can buy. So I'm in favor of trying Ologen in fast case, in my fast, rather than the tube. Okay, so we plan for Ologen in this case, and the patient did well, but in the first follow day, maybe due to the hypotony, that loosening of the suture, etc., I might not have tightened the suture properly. So we first felt that AC was shallow in first post-op day, the hypotony, and it lead to, as you know, that hypotony lead to CD, CD lead to the hypotony, is a vicious cycle. So we tried again with oral steroid, and for the CD, as I want to say to resident that in first post-op, first, second, third post-op day, if there is a hypotony, AC is shallow, then you have to do a schedule test to see whether there is a bleb leakage, any bleb leaking is there, etc. If not, then you dilate and see what is happening in back. If you cannot find, do a gentle ultrasound. You should see the periphery of the retina to the peripheral CD. If you are finding CD and you are not looking any leakage, so you should start a steroid. Okay, and if after 7 days of steroid also the CD has resolved but not up to the standard, so I thought to opening the bleb again, I tightened some scleral suture, 2 to 3 scleral suture and side. Then the patient did well, and we sent the patient home. But after 2 to 3 months, again I found there is a bleb was slightly failing, IOP was slightly more side. Again I planned for a bleb revision with mitomycin C, and then patient will that was 12 millimeter mercury, and the patient was sent. And patient last 6 months back, the patient came with good. It was a perfect 10 to 12 millimeter IOP, and you can see the bleb is looking very nice. That is the what is the perfect definition of bleb: relatively avascular, diffuse, microcystic bleb, and mild, moderate, elevated elevation. I cannot say this is maybe due to the Ologen, etc. So I think this second case, the bleb is working well, and it is nearly about 2 years now. So hope it will work more. So I want to emphasize that Ologen is not Ologen you can try for this type of cases, because in tube surgery, although they say that the tube and trabeculectomy, they say the initial success rate is equal, like 70%. But at the 5 years, the trabeculectomy has 30% success, and this tube has 50% success. But these are not without any complication. Tube-related complications, as you know, tube has many complications. Tube lengthening, tube erosion, tube touch, endothelial touch, etc., etc. And especially these patients have endothelial decompensation. So I am slightly not in favor of tube in this type of cases. If my normal trabeculectomy and Ologen with Ologen is working well. So these were 2 cases we presented, and my the last thing is to say the residents that you should focus on the endothelium, this type of atypical things, like when you are seeing iris abnormality, etc., to try to find out. And obviously these are having different times like PPMD, fixed dystrophy, axon field region anomaly, and you should read what are the differences, how we differentiate from all these. And these 2 cases were a clear-cut IC syndrome with variability like progressive iris atrophy and Chandler syndrome. So thank you from my side.
Thank you,
Any
Dr.
question?
Bhagwat. Yeah.
Yes, sir.
Thank you. I think any questions from the audience or anybody? We can have a discussion on that.
So I'd just like to ask one question from Dr. Nikita, sir, for the first case.
Dr. Erickson. First case is Dr. Erickson.
No. The first case of the
First case of the second presentation.
Yes, sir.
Yeah.
What she mentioned that there was a corneal edema in the right eye. She could not do NCT. She did a applanation tonometry. Is it possible to do a applanation tonometry to find out the intraocular pressure in such edimeter size?
So much.
Sir, actually, we did try an NCT, but it came over. It did not give a reading. So unfortunately, so we had to try a Goldman applanation tonometry.
So can Goldman applanation tonometer measure in such kind of cases?
Yeah, it may not be accurate, but at least we had a reading. So that is the main important thing. Because the other things we could not try the NCT. We do not have a shields, so we need a reading. So what do we do? Of course, there are other instruments that are better in cases of corneal edema.
Yeah,
And Goldman applanation will not be exactly the best best instrument when it comes to corneal edema or corneal scarring. But then when you have nothing, you have to do something. So
yeah, absolutely right. So in these conditions, probably even the old-fashioned Seod stonometer can.
So Sears is the best in these cases.
Yes, sir. You can do also digital tonometry if you are experienced.
That gives a very good idea also.
Yes, sir. Although Goldman will not obviously it has some error, in corneal edema, but at least some idea to get the idea.
Yeah, but both the cases were excellent, and your explanation, Dr. Bhakati, was also excellent. It clarified everything.
Thank you, sir.
It was never thought of that such a cornea will give rise to a vision of 636.
Yes, sir. So the only thing I foresee is that these patients need a regular follow-up.
Yes.
Usually one has to start with medicines, medical management, and when the medical management starts failing, then you have to go for the surgical management.
Other thing is the early diagnosis, because one eye they had this corneal opacity, the other eye also, that would have also gone to the same place had it not been properly taken care of.
And there is always a possibility of doing several surgeries. If one surgery, one trap can fail, you can select another location for trap. If that also fails, then you can have a tube also. So multiple surgeries, the option has to be kept open.
Yes, sir. I want to say, yes, as I rightly said, first to Dr. Sabisir, sir. Yes, sir. The second case vision was quietly improved, and she's doing well till now. And about that repeat surgery, yes, we should know in our foresight that we should make the trabeculectomy or Eulagen Jobi in the one quadrant. Especially, I do on supranasal quadrant. At least leave space for another trab if required. Don't do in middle of the conjunctiva, middle of the quadrant.
Yes.
And you have to vigorous. That means vigilance over the. That means the process of the trabeculectomy. After 3 months, 6 months, you have to see for what is happening. Then you will intervene accordingly. Thank you, sir.
It needs a long-term follow-up.
Yes, sir. Yes, sir.
Lifelong follow-up.
Long-term follow-up, confidence of the patient on the treating physician. There are many things involved in this type of case. You would have a lot of patients also to handle them. Lot of frustration, questions, other things you have to deal with. And then finally you will come out with a situation when at least the patient can see, you will not go blind. Ultimately, the aim of our being ophthalmologist. Thank you all. I think we had a very nice beginning, this grand trial.
Really fascinating, sir. It's really good. Your vision, I mean, tremendous hats off to it. 2 cases and all thoroughly explained.
Yes.
Pranabji, and next case presentation should come from your Patna, RIO.
AIMS Patna or RIO Patna. I'll just
ask Dr. Vibhuti to prepare.
I'll just ask him and get back.
What to Dr. Vibhuti? Okay.
Either AIMS or
This will give us a forum to know also the people who are doing good work in their institutions.
Yeah, and there should not be too many cases. I think 2 cases what we discussed today is
very good actually.
Absolutely right. Absolutely right. 1 hour. 1 hour is sufficient.
1 hour, 2 cases. I mean, there are a lot of webinars who pack a lot of cases, 4 or 5 cases. I mean, that is not fair.
No.
Very brief. It should be very brief also. The discussion should be very brief. Right. And we should have enough time for the discussion by the residents also. We should involve the residents. Let them ask.
No, this grand round was a grand opening.
Yeah, definitely.
Thank you, sir. Thank you very much.
So once the discussion is completed, I'd like to give the customary vote of thanks on behalf of the doctor who was supposed to give. But due to poor network, he SMS'd me. He could not.
Great. Can you stop sharing?
Thank you, sir, for giving us this opportunity.
Thank you very much, madam, for agreeing.
Just on his behalf, let me thank first Sucheta madam and the presenter, Dr. Janikson. Next, Dr. Bhagavat Nayak and the presenter Nikita Dash. It could be very nice if we could see you in the video, at least for some time. It could be very nice. Most welcome. And our chief coordinator, Dr. B.N.R. Subudhi sir, as usual, making control of all the things. And my sincere thanks to our president and the brain behind the chairman scientific committee, Dr. Sabashachi, and the audience. Today, really, we had a very few audience. Maybe in the YouTube, people will see. Never mind. Our endeavor will continue, and this type of show will go on. Thank you so much.
Thank you.
On behalf of the EIZOC.
Bye.
Thank you, everybody.
Thank
Okay.
you.
Bye
Thank
then.
you,
Bye.
Doctor.
Bye.
Bye bye. Thank you, Suraj. Thank
Bye.
you.
Thank you very much for the
Thank you
nice
very much
presentation.
Thank you.
to
Neha.
everybody.
Oh, lastly, yes, Ajanta Pharma. Yes.
Ajanta.
Thank you, sir.
Ajanta Pharma for the support.
And thank you,
Very
Subodhi,
sorry.
sir.
Thank
So
you.
we are always here to
Thank you
support
so
you
much.
all.
Thank
Yes,
you.
sir.
Thank you.
Thank you, sir.
Sir, thank you
Thank
also.
you all. Thank you very much
Thank
for
you.
your.
Thank you, Dr. Mayor.
Now, the
Thank you.
discussion was
Thank
excellent.
you, sir. Yes,
Yes.
sir. It was really, very informative, even for us also. We got lots of insight. Throughout the session, I was, hearing that excellent presentation.
You will also become an ophthalmologist specialist. Don't
No,
worry.
sir, that,
We are working
that
on,
is,
Continue
we are
to
working on
support us for 3
anti-glaucoma
years.
products.
You'll become an ophthalmologist. Thank
Sir
you.
Ranjan sir, we are just trying to understand the
Yes,
area
yes.
where we are operating.
No,
So thank you, sir, for a wonderful scientific session. Thank you, Dr. Nikita, and thank you,
And
Dr.
I
Jayant.
like to request from this platform, the young brigade who are
Yes.
not yet the members of EIZOC, please do it and make it online and do it. Please.
Sure, sir. Sir, I'll just stop the